and now we're going to move on to something a little bit less complicated, the spine. And I want to talk a little bit about a tool that's been alluded to by some of the earlier speakers today, our value-oriented architecture tool that we are starting to use in Providence to help us drive to doing a better job for patients at the same time that we work on controlling costs. One of the other things that many of the speakers have mentioned is that all of these initiatives are underpinned by a collaborative environment and by a desire by the people providing care to use the information in a productive way. One of the questions that I want to talk about a little bit first is the sort of journey that we went through in trying to create this environment in Providence and how that underpins us being able to use VOA today. So when this all started a few years ago, Providence was organized primarily as a holding company. That meant that most of the decision-making occurred at the local hospital level. Physicians tended to have a relationship more with their local medical staffs and their hospital administrators than they did with one another across the system. We had about 250 spine surgeons. Some were employed, some were aligned, some were neither. And they were working at a total of about 32 different institutions across these 5 states. So a lot of geography to contend with as we began to draw people together. We asked the orthopedic spine surgeons, the neurosurgeons, and the neurologists to come gather in Renton, which is near Seattle, to begin to think about how will we put together a neuro institute for the Providence system. And we talked about their ideas. How should we segment neurologic care in the system? What areas should we focus on first? And what sources of data were going to be needed for people to do their jobs as effectively as possible? At this same time, we were in the midst of implementing EPIC, which any of you that have been through that know is something that really drives to the front of your mind while you're doing it. And this promise of having a database that extended across all of these 5 states and thinking about how to use that was kind of in the forefront of all our imaginations. And so the request repeatedly from all of the subgroups was we need sources of data, we need to be able to put all of this information to work so that we can drive this change. So we were all looking forward to making change, but it was a little bit unformed as to what shape that change would take. Well, it was going to take a while to put those tools together, and so while the tools were being assembled, we began to look for other ways to collaborate, other ways to build this culture for these 250 people who really hadn't worked together much, and some of whom weren't really very effectively aligned with our system. One of the first things that we put effort into was coming up with a system-wide spine hardware contract. So as I mentioned, we were a holding company at this point. We had about 37 different vendors of spinal hardware across our 32 hospitals, and the relationship with those vendors was defined by 70 different contracts. So a lot of inconsistency, a lot of uncertainty. We got the surgeons together with the support of supply chain, and over a period of a few months, were able to come to an agreement that we would settle on 6 of these vendors, and we put together system-wide contracts with these 6 vendors. The ask of the vendors was, give us the best price that you have given any one of our hospitals and spread that across the system. And all of the vendors were willing to do that with the exception of DePuy. So DePuy was left out of the contract. At that point, they were responsible for 13% of our volume. So that meant there were a lot of people that were going to have to figure out who their implant of choice was going to be going forward. This was really a pretty big ask as an initial step with the surgeons coming together. And because we had engaged everybody throughout the process, and because everybody had had a vote in the final decision, the change was made. And over about 3 months, we got to 94% compliance. So this was kind of our first big bite of the apple of starting to work together. We next had to figure out how to maintain this compliance. So the contract cycle is usually a couple of years. During that time, new products inevitably are going to come onto the market. And again, back to the holding company model, we were all used to going to our OR manager and saying, hey, I want this new thing, will you get it for me? And oftentimes the answer was okay. Every once in a while it was no. Well, that local level management probably wasn't going to work with a system level contract. So we needed to create a new product review committee at the system level that somehow maintained its regional and local connection. So we asked for representatives from each of the regions across the 5 states. These folks would get together by phone about once a month to consider new product requests, and they were the decision makers. It was a physician-driven process. And so a new request would come in, the submitting surgeon would get on that monthly phone call, there would be a conversation between all of the involved parties, decision was reached, and if that was going to be a messy or adverse decision, we asked one of the regional folks to speak with the requesting surgeon and give them the bad news so that it felt as still kind of local and friendly as possible. This worked pretty well, and now we're at 99% compliance. So we have been able to kind of keep the ball rolling and moving forward and still have this be a surgeon-led process. This is a little bit difficult to see, but we also began to introduce transparency of data in this time so that we could have conversations with each other about how we were doing this work. So behind the picture of the spine is a graph with a bunch of colored dots on it. As each of those dots represents the cost for a surgeon for a 1-level cervical fusion for the implants. And we have a range of costs between about $2,000 and $4,000. Because this information was presented in an identified fashion, it got us used to conversations with each other about how do you do this, and also accepting the fact that we needed to share at this level if we were going to succeed. Another thing that we worked on was preoperative preparation of patients for surgery. So the first step was to create a dashboard like this. We focused on 4 areas: BMI, pre-op narcotic usage, pre-op smoking, and hemoglobin A1C and blood sugar in the diabetic population. The spine committee kind of took this menu of possibilities and settled on smoking cessation as the first thing that they wanted to work on, and we started this in kind of late 2015, early 2016. This graph is a little hard to see, but each of these points is the rate of smoking at an individual hospital. So you can see we had a pretty fair degree of variability across the system. Rates as high as 20% in Alaska, where it's dark and cold for a lot of the year, and rates that are much lower down here in California where it's warm and people can get out and run and look after their health. The goal was to blend those rates and get across the system to a lower aggregate rate of smoking for all of the patients that we were operating on. Well, you have to do more than set a goal. You also have to support the people who are going to do the work with some tools. And so we created a registry that was accessible for patients of all of the smoking cessation tools that were available across the 5 states. That was an online registry that any of the patients could log into. We also created letters that could be shared with patients and with referring doctors to help them understand why smoking cessation was important, and not only for getting through the surgical encounter with good health, but also so that their fusion worked at the end of 3 months or 6 months. And at the end of the day, we have had pretty good successes working as a team on this, bringing the aggregate pre-op smoking rate down to about 8% over this 3-year span of time. In both of these efforts, there had to be give and take. There had to be individual changes in practice pattern. There had to be buy-in, and there was a lot of creation of culture to get us ready for some of what was coming next, which is this harder work that really is going to be much more disruptive to how we deliver patient care. And so into this more collaborative environment came the VOA tool. You've seen this graph already. Where you want to be is the upper right-hand quadrant. Each of these circles represents one of our hospitals, and as you have heard before, the size of the circle correlates to the number of spine procedures done at that particular hospital. As the tool was being put together, there were 3 important decisions that were made. Surgeons tend to think about themselves in comparison to their peers on a procedural basis. So if you do a fusion from behind, how does it work? If you do a fusion through the stomach, how does it work? If you do a fusion from the front and back, how does it work? We wanted to address the disease process as we started to do this value-oriented procedure, not the way that the disease was taken care of. And so when the value plot was created, it was created blind to the way that the procedure was done. And so the cost and outcome is compared not for a fusion from the front or a fusion from the back, but for a fusion of any kind, taking care of degenerative disc disease. We also stratified the data by level. In DRG world, all fusions are pulled together into a bucket. And so when trying to compare costs in that kind of an environment, it was always very difficult to tell if the difference in costs was a result of the average number of levels that the surgeon fused, or whether it was really a material difference in the way that they were doing their work. Natural language processing was used to look at the op notes and break the procedures into these buckets that you see here, and that allowed us to do a more direct comparison of the way that one of us was carrying out the work relative to another. In terms of outcome measures, as was mentioned before, this was kind of done in collaboration with the people who do the work. It was, as Amy said, you had to get past the give a darn test. And we broke these into 3 categories. First was things that occurred in the hospital. So how long were you in the hospital, and did you have to go back to the operating room after the first time? Second was, what did I have to go through after I got home? Did I get to stay home and get to gradually feel better there? Did I have to come back to the emergency room? Did I have to be readmitted? Did I have to be operated on another time? And then last and most important is, did the surgery do me any good? Numbers vary, but you know, if we're being honest with each other, about 40% of the time spine surgery doesn't help people feel dramatically different. So as we are trying to change our treatment paradigm, we really want to dig into that and try and understand why. Is it the way that we're doing the surgery? Are we not choosing the patients correctly? Which one is it? And the way we hope to get at that is with patient-reported outcome differences at the end of 12 months relative to before surgery. There's a lot of detail in this tool. So as opposed to many other cost things that have come along over the years that are at this level up here, we can really dig into this and understand exactly what we've done. And so as you see from this page on the right, we can understand what vendor was used and what particular pieces of that vendor's catalog were used in carrying out a fusion as we're sort of digging into the supply side of the equation. A little bit more detail about the tool itself. When you first log in, you see a set of circles. Each of these circles represents a surgeon. If you hover over the circle, you see the surgeon's name. Again, trying to create an environment where we will communicate with each other about how we're all doing the work. We have a little bit of variability to deal with. The average cost of a one-level fusion in our system ranges between $8,000 and $28,000. So we need to clump that up a little better over the coming years. The surgeons' names come up in the next part of the sheet, and the supply costs are broken into these 8 buckets. Supplies, time in the hospital, therapy charges, radiology charges. The orange line is the average cost for the 3 least expensive surgeons, and the blue line is the average cost for the system. When we're trying to decide whether to use a new implant or not, we often ask, what difference is it going to make in how long the patient is in the hospital or how long it takes to do the surgery? And so we wanted to have that information right out in front so that it was part of the initial snapshot before we begin to dig into it more deeply. These lines represent all of the surgeons. The blue lines represent the 3 that you see there, and you have time in the operating room and time in the hospital. And then we have the outcome measures that I mentioned before. So we had this great new tool. We were ready to go. It had been vetted. It was beginning to pull data into it. And like any new software, it turned out that it wasn't perfect after all. Now, the reaction that could have provoked was, Lucy in the football, you've done it to me again. You've taken me through this before. The data's never any good. I'm done. I'm not going to listen to you anymore. But fortunately, that is not what happened. I would like to think because of some of the work that we put in the years before. And what went on instead is people said, let me help you out making the data better. And so we established a physician group to begin to bring their observations about where the data needed to be improved forward. We had also at the local level, the people who are very good at digging into the data was put into another group. They worked together to inform Caleb's team about observations that they'd made, and the clinical analytics group with support of healthcare intelligence continues to work to improve this. We're now on a cycle where about every 2 months there's an update to the tool, which continues to refine it and continues to make it more usable and continues to give all of us more confidence in the available information that we have. I'm talking about spine right now, but we have these in other areas as well. I think you heard from Dan earlier today. We have them in PCI and CABG. We also have them in hip and knee replacement, cholecystectomy, colectomy, appendectomy for the general surgeons, and then normal delivery for the OB docs. And so here's an example of some of the early work. This is data from Swedish hospitals in Seattle. In the left-hand panel, you see the 2017 baseline. So for each of these 5 categories of procedure, you see the number of cases that were done and the average cost per case in that baseline period of time. In the middle panel, for the first 6 months of this year, are again the number of cases that have been done and the change in the average cost. And then there's a new panel next to that that shows, therefore, the aggregate savings based on the change in cost relative to the baseline year. You also get a good snapshot of which way your trend line is going. So the blue line shows over the several months, are we saving money and going down, or are we getting more expensive? And the peaks and valleys in gray behind show the month-to-month deflections in expense. So this is kind of the aggregate experience at Swedish so far. We've had about a $900 reduction in supply cost across this aggregation of procedures, of about $400 per case reduction in anesthesia costs. So we have a great new tool to work with. We have a system put in place to continue to improve on that tool and make it be usable information, and the future looks pretty bright. But I think as many other speakers have alluded to today, without the kind of collaborative environment underpinning this, I'm not sure that we would be making the progress that we are up to this point. Thanks.